Hello everyone. Today we will be discussing about bradyarrhythmias. Bradyarrhythmias, arrhythmias are disorders of the heart rhythm. So it can be, depending on the rate, it can be either bradyarrhythmia or tachyarrhythmias. So the normal heart rate is 60 to 100 beats per minute, and any arrhythmia, any rhythm disorder which is too slow is called bradyarrhythmia, or bradycardia is when this is in sinus rhythm, sinus bradycardia, or if the rhythm is not sinus rhythm, then it is called bradyarrhythmias if the heart rate is, the ventricular rate is less than 60 per minute. So here we can see that this is the sinoatrial node in the right atrium, where the impulse usually is generated and conducts to the atria, and then through the atrioventricular node it conducts to the ventriculus by the bundle of His and Purkinje fibers. Mechanism of arrhythmogenesis, as we can see here, altered impulse formation can be of two types. Either there is enhanced automaticity which will lead to tachyarrhythmias, or there can be decreased automaticity resulting in bradyarrhythmias with a decreased heart rate. The second mechanism of arrhythmiogenesis can be because of the conduction, altered impulse conduction. If there are re-entry pathways, then they will lead to tachyarrhythmias, while in cases of conduction blocks, it will result in bradyarrhythmias. Now the classification for arrhythmias based on whether the abnormality is in conduction or in the automaticity. Bradyarrhythmias, there are different types of bradyarrhythmias, wherein those with altered or abnormal conduction are, if the conduction block is at the level of SA node, as we can see in sinoatrial block, or at the AV node, AV block diseases. Because of abnormalities in the automaticity, we can see sinus bradycardia in cases of bradyarrhythmias. While in tachyarrhythmias, the conduction abnormality is usually re-entry pathway, like there can be SA nodal re-entry, or can be intraatrial re-entry tachycardias, then AV nodal re-entry tachycardias, AVNRT, then at the level of ventricles or any accessory pathway. Increased automaticity resulting in tachyarrhythmias, the examples are sinus tachycardia, ectopics, junctional tachycardias, ventricular tachycardias. Okay. Other important arrhythmias are also multifocal atrial tachycardia and torsity de Pointes. Now coming to bradyarrhythmias. The importance, as we have already discussed, that it begins with the etiological understanding. What is the cause for this bradyarrhythmia? So there can be a defect in the impulse formation, or there can be a difficulty in the impulse conduction. Bradyarrhythmia, disorder of sinus node function and AV conduction disturbances. Both these will lead in bradyarrhythmia. Either the impulse is not being generated, like sinus node pathways diseases, and conduction abnormalities which can be there in the AV conduction, or later in the His and bundle Purkinje fibers. Sinus node dysfunction, sinus bradycardia. Here the sinus node discharge decreases, and it is at a rate slower than 60 beats per minute, though the rhythm is normal as such. So every P will be followed by a QRS, normal QRS complex, but the rate will be less than 60 beats per minute. The ECG manifestations are that P wave has a normal contour followed by a normal QRS complex with constant PR interval of more than 120 milliseconds. The causes can be physiological, like in trained athlete without any structural heart disease or without any obvious cause, we can see this sinus bradycardia, which is because of high vagal tone. During sleep also usually there is sinus bradycardia because of the vagal effect only. Then pathological causes of sinus bradycardia are hypothyroidism, hypothermia. Also in case of raised intracranial pressure we can get bradycardia. Then obstructive jaundice, uremia, acute hypertension, gram-negative sepsis, fibrodegenerative diseases, some of them. Then sometimes some drugs can cause, like digitalis, beta blockers. Inferior wall MI also affects the sinus node, and it can result in sinus bradycardia. Here we can see that here the rate is less than 60 per minute. We can count the larger boxes: 1, 2, 3, 4, 5, 6. So 300 divided by 6 is 50. So the heart rate is somewhere around 50 per minute. Coming to sinus arrhythmias. Here ECG characteristics, the presence of sinus P wave will be there. Whenever we are using sinus arrhythmia, then there will be a sinus P wave, normal P wave. Morphology will be normal. But the variation of the PP interval, which cannot be attributed to either SA nodal block or premature atrial complexes. So here the PP interval is changing, but it is not falling in the category of either a SA node block or in premature atrial complexes. So other findings, other features of these diseases will not be there. This is called sinus arrhythmia. When there is variation in the PP interval with respiration, this is without any other findings, and this is considered to be a normal variant. When they are unrelated to respiration, they may be caused by same etiologies leading to sinus bradycardia. So if there is changes with phases of respiration, which is usually seen, can be in the normal patients also, normal people also, it is sinus arrhythmia. While if there is no relation with the inspiration, then it can be either physiological or pathological, as the causes can be same as we have discussed in sinus bradycardia, that is hypothermia, hypothyroidism, etc., uremia. Now coming to sixth sinus syndrome. Sixth sinus syndrome, there is a structural nodal disease. It is characterized by a collection of symptoms and ECG findings due to chronic dysfunction of the sinoatrial node. There is chronic and severe sinus bradycardia. There are sinus pauses, sinus arrhythmia, complete sinus arrest, progressive development of atrial arrhythmias like atrial fibrillation or flutter or atrial tachycardia. These all can be there in structural nodal diseases. These patients are usually elderly, and they present with complaints of lightheadedness, or sometimes there can be history of syncope, but it can also manifest as angina, dyspnea, palpitations. About 50% of people with sixth sinus syndrome also display some degree of dysfunction of the AV node. So AV node conduction are also affected here. Here, for example, the ECG of sixth sinus syndrome is, we can see that there is sinus bradycardia. The rate here is less than around 43 beats per minute, and there is sinus pause. We can see here. We can see sinus pause. Etiologies of sixth sinus syndrome. There are many causes of sixth sinus syndrome. The commoner causes are sinus node fibrosis or atherosclerosis of the sinoatrial node artery, congenital heart diseases, or there can be excessive vagal tone, and few drugs. Less commonly, familial sixth sinus syndrome can be seen because of infiltrative diseases. There can be sixth sinus syndrome, pericarditis, Lyme disease, hypothyroidism, rheumatic fever. They can also sometimes present with sixth sinus syndrome. Now coming to tachycardia, bradycardia syndrome. Common variant of sixth sinus syndrome. Here, severe bradycardia is alternating with paroxysmal tachycardias, and most commonly this tachycardia is atrial fibrillation. There is usually a prolonged pause in the cardiac rhythm following cessation of the tachyarrhythmia. Here we can see that initially there is flutter waves, and then there is abrupt cessation. So sinus arrest is there. Okay, and then the first beat, this is without a P, this is a junctional escape beat. Now coming to AV node 2 blocks. Here there is abnormality in electrical conduction between the atria and the ventricles. There are many types of AV blocks, mainly 3 types depending upon the severity. The first degree AV block is the least severe one, where there is a delay in conduction, and except for the widened PR interval, we don't get any other abnormalities in the ECG. Second degree AV block, here there is intermittent interruption of the conductions, and there are changes in the PR intervals with the also in the ratio of the impulses propagated to the ventricle, that is the P and QRS ratio also is altered. Third degree AV block is a severe degree of disease, and here complete or permanent interruption of the conduction between the atria and ventricle can be seen. Now coming to first degree heart block, it is a delay in conduction through the conducting system. There will be PR prolongation of the PR interval, and it will be more than 0.2 seconds. All the P waves are followed by QRS complexes. There is no drop. The causes can be coronary artery diseases, in acute rheumatic carditis, and because of drugs like digitalis and beta blockers. So here we can see that there is prolonged PR interval. So here you can see the PR is more than 0.2 second. Coming to second degree heart block, here there is intermittent failure or interruption of the conduction. Regularly occurring P waves, some of which are not followed by QRS complexes, can be there, so conduction ratios vary. The causes can be physiological, there can be fast supraventricular rhythm, then also some pathological causes can cause second degree heart block, commonly like rheumatic carditis, diphtheric carditis, coronary artery disease, and digitalis induced. Now there are two types of second degree AV block. The first is Mobitz type 1 block, or it is also called as Wenckebach phenomenon. Here there is progressive change in the PR interval. The PR interval gets prolonged with each successive beats until a beat is dropped. So here we can see that this first one PR interval, then here the second one PR more in, it is lengthened, then this is lengthened, and here it is dropped, and then again it starts with a shorter PR interval and then gradually widens. Lesion situated in the AV node itself. Here the lesion is in the AV node itself. It can be physiological or pathological, and usually carries no adverse prognosis, but monitoring is required. Mobitz type 2 second degree AV block. This has a fixed relationship between the AV conduction. So PR intervals of all the conducted supraventricular impulses is constant. Lesion is situated in bundle of His, and it is always pathological. And it usually carries adverse prognosis because it may progress to complete AV block. The causes can be MI, the causes can be because of sclerodegeneration of the conduction fibers. Here we can see in the diagram that there are two P waves, and while only one of them is conducting to the QRS. So this is the P wave conducting, then P wave no QRS, then P wave with QRS, then P wave with non-QRS. So 2:1 ratio is there between the SA node and AV node conductions. Then coming to third degree AV block, there is complete AV block. So when a fast or relatively fast supraventricular rhythm is completely dissociated from a slow idionodal escape rhythm of less than 40 beats per minute, or slow idioventricular rhythm of less than 35 beat minutes, and long recording fails to reveal any capture beats, this is called third degree AV block. So now none of the impulses generated in the supraventricular part is conducted to the ventricle, then it is called third degree AV block. ECG criteria, there is AV dissociation, no relationship between peak waves and QRS complex. The ventricular rate is slower. In case of idioventricular rhythm, it is 30 to 35 beats per minute, and at the level of bundle of His, it is the 35 to 40 beats per minute. The ventricular rate here will not be affected by exercise, emotion, respiration or atropine. That acts at the SA node. So QRS configuration, if subsidiary pacemaker is situated in lower AV node, then QRS AV node proximity में होता है, तो then QRS complex is normal or near normal in shape. While if the subsidiary pacemaker is situated peripherally in the ventricular musculature, there will be broad, bizarre, notch, slurred QRS complexes. So as the distance between the subsidiary pacemaker is increased in relation to the AV node, the QRS complex configuration will be more and more bizarre and widened. Now, causes of complete AV block. Chronic complete AV block, most common causes are idiopathic sclerodegenerative diseases, example Langer's disease, then fibrocalcareous encroachments, Leaves disease, then it can be seen in coronary artery diseases, intracardiac surgery, digitalis intoxication, then some tumors, parasitic infestations, pyogenic and granulomatous infection, they can also cause the conduction fiber abnormalities leading to complete AV block. Stokes-Adams syncopal attack or ventricular systole. Now this is a condition where syncope results because of the conduction blockage. It is a syncopal attack resulting from ventricular asystole, and this occurs in third degree AV block usually. Circumstances during the transition from incomplete to complete third degree AV block, it can be seen when two or more ectopic pacemakers are in competition, or paroxysms of ventricular fibrillation can lead to Stokes-Adams attack. High grade AV block, blockage of two or more consecutive supraventricular impulses at a rate of 140 per minute or less, is called high grade AV block. Now coming to congenital AV block. Here the block nearly always within the AV node due to maternal anti-Rho antibodies. The QRS complexes are normal. The idionodal rate is 55 to 65 beats per minute. Ventricular rate is less stable than the acquired complete heart block. That is, it fluctuates with emotion and exercise. Syncopal attacks here are very rare. Conditions associated with congenital AV blocks are corrected transposition of the great vessels in patients with ventricular septal defects, and ostium primum type of atrial septal defects. Thank you.